This is our first lecture in the chronic neurological disorders, and we're going to start off with headaches. Um, what I want us to focus on mostly, and what I think that you'll find mostly on NCLEX, are going to be migraine headaches. The other type of headaches, we're going to do just a lot of health promotion. Think strictly least invasive to most invasive. So we know that headaches are classified as either primary or secondary. It's a nice way of saying they're either there or they're related to some other underlying comorbidity, just like you would with hypertension. So on this illustration, we kind of see the general outline of where we would expect clients to report signs and symptoms. For us, the biggest ones are going to be in that first row. We're going to talk a little bit about tension headaches, a lot about migraines, and a little bit about cluster headaches. And you notice when we do it, you have very specific locations and very specific signs and symptoms that we would be looking for. So from the overall standpoint, what can I do as a nurse? Honestly, other than medicate, educate, and provide comfort, there's not a lot that we can do. So we're going to walk through those processes. So obviously, we're going to promote stress management strategies. That's basic 101, health promotion and disease prevention. And we're going to be able to recognize and help the client recognize how to avoid triggers. We're going to talk a lot about headache diary. I think that that's more of a specialized thing. If you go and see a neurologist for headaches, they may be asking you to do something about those. But it is a very non-invasive thing that we can do to help the clients learn how to kind of track these triggers and what's going to cause these headaches. So we know that there are a lot of things that can cause a lot of issues as far as health is concerned. We know it's alcohol, environmental allergies, sometimes intense odors and bright lights. When we talk about planning for a client, one of the things we always say is to make sure that it's decreasing stimuli, especially that external stimuli. Of course, the stress and everything goes along with having fatigue, sleep deprivation, depression, other emotional or physical states. For our female clients, it could be menstrual cycles and the use of oral contraceptives, or general foods. So you'll maybe see some questions on NCLEX about MSG, nitrates, milk products, things that are going to help trigger those types of headaches. Okay, so here we kind of have a breakdown. And to me, when I look at this, when I'm seeing three things, that's always about making sure that you can differentiate one from another. So with NCLEX, I would maybe expect something like a categorization type of question. So with tension type headaches, you can see that it's usually bilateral. It's going to be consistent with a band around your head. It's constant. It's squeezing tightness. Anywhere from 30 minutes to 7 days. That'd be a little hard. You can't really narrow that time frame down. It's not related to a specific time because you see such a broad range. And often you will have this palpable neck and shoulder tension, and that's how we address it. It's usually caused because of some of these muscle issues. For migraine headaches, we're going to say it's unilateral, so in 60% usually, it may switch sides, and it's more common in the front anteriorly than it would be posterior. They describe it as throbbing and in time with a pulse. We're going to look at pounding. Can last several months to years, can last 4 to 7 hours. I would say the biggest one for the migraine, since that's the big one we're going to talk about, is we're going to talk about these prodromal periods and the post-dromal periods. So it's this pain that is going to be there. It gets worse when you wake up in the morning. It can get better with sleep. It is going to activate a little bit of that sympathetic nervous system. So I would expect some nausea, vomiting, irritability, diaphoresis. Your photophobia and phonophobia, so you have sensitivities to light and sound. We talked about you can have these prodromal periods, and usually with migraines, there's some sort of family history. For cluster headaches, again, it's unilateral, and it radiates up or down from the eyes. They describe it as severe and bone crushing, and that's how I put the crushing with the cluster, so I know my C's match. Again, you have differences in time. You will see, though, that this one typically will only be 5 minutes to 3 hours. More typical at night, so this one may wake you up from sleep. So we're seeing the differences between the migraine and the cluster. I would also expect, because it's this type of pressure, that you may have some sort of facial flushing or some sort of loss of color, that pallor. Changes in your eyes, and you may have a runny nose. And again, because it's behind that eye, I would kind of expect some sort of tearing, lacrimation. Okay, so here is just a general illustration of a tension. You can see it wraps around the head. The migraine, where it's this unilateral, anteriorly positioned, but again, it can switch sides. And then the cluster headaches, you see it's mostly centered around this eye area, but it would go further down. And again, the red is the most frequent type of sites that you would see, but of course, all pain can radiate. So with the big one, the one that we probably care most about, you're going to have to understand that these clients are going to go through a process. So you have this prodromal stage, right? So hours to days before onset, they'll display those kind of sympathetic nervous system signs and symptoms. They kind of basically know that they may be getting a migraine. And that's something that our clients will often say to us is, I think I'm getting, or I think I'm starting to get a migraine. So following the prodromal stage, they'll have the aura stage, can develop over minutes to hours. They can experience, they don't have to though, they can experience paresthesia, paresthesis, tingling of the lips, face, hands. They can have acute confusional states. Think sometimes that like their thinking is clouded, so they may say things to you that they have already said to you and they don't even remember saying those things to you. They can have visual disturbances, bright flashing lights. Here in the picture we kind of see what an aura is illustrated as. They would move on then to the second stage of a migraine. They can have severe and incapacitating throbbing headache. So it's going to get worse and worse, and it's going to lead to nausea, vomiting, vertigo. And again, the third stage, it's kind of calming down now. The headache is dull. It may or may not have an aura. And then the recovery period is going to happen for them. So that pain and the aura that they're experiencing may start subsiding. Muscle aches and contraction of the head and neck muscles are common, so you stiff kind of neck. And then physical activity would make, at this point, the pain worse, which may lead to them not being able to sleep. So when we're looking at this, we have these expected findings for the migraine headache, right? So it's photophobia, phonophobia, and a pulsatile headache. So those are P's. Hours to days, it's unilateral. It can be associated with nausea and vomiting. It makes your ADLs difficult, and it causes and is caused by stress and anxiety, among many of the other triggers. So migraines, you see that how they affect our body overall. Head pain, you have this cognitive fog, you can have garbled speech, sensitivity to light, sensitivity to touch, strong odors, sounds. Then you have that general kind of malaise, fatigue, the neck pain, the blurry vision, and the nausea and vomiting. Our goal is to terminate or decrease the symptoms. So we're going to go through the different stages here, mild to moderate to severe, and we'll just look at that. Most of these we're probably really familiar with. So for mild migraines, again, this is something that your patients probably know is going to happen, or you can talk about teaching when you feel a headache coming on. We can use ibuprofen or naproxen. You'll see that sometimes even those medications themselves are going to be mixed with other medications. Tylenol, obviously. Or we can have other anti-inflammatory medications. So think like naproxen. They have different medications over the counter that are specifically for migraines. They probably contain at least a little bit of caffeine. So we would be thinking about like a Excedrin migraine or an Advil migraine. Again, those are those just over the counter, Motrin, whatever it may be. We could, if we know that it also causes nausea and vomiting, we could expect maybe an antiemetic such as metoclopramide. And then again, we said we have those combination medications where you'll have a beta blocker, so something like propranolol that is going to be mixed with your NSAID medication. So anything that promotes that kind of vasodilation, we see propranolol, we see calcium channel blocker, that's probably nicardipine, nifedipine. And then of course you can have, in addition to these anti-epileptic medications, Valprorex or Topramate. And again, you want to make sure that you're not using those, generally speaking, as a first-line medication. Those are going to be used when we know that something is coming on and are going to be used every once in a while, or I shouldn't say every once in a while, I should say less frequently than we would expect these other ones, medications to be used. So for moderate to severe headaches, we're going to come back to the triptans. They're the first line of therapy, and again, but it has to be moderate to severe. So sumatriptan, Topramate can also be added or in addition to. Topramate's an anti-seizure drug. It can be taken daily, more of a preventative medication. But again, these medications have a lot of bad side effects. So you see here Topramate, hypoglycemia, paresthesia, weight loss, cognitive changes. I know that's hard for me to ask about because a lot of those signs and symptoms are exactly what we're giving the medication for. So make sure that if we're talking about adding in some sort of Topramate or something like that, we're actually using it as adjunct therapy. For our drug alert here at the bottom with the sumatriptan, right? So if they have a history of ischemic cardiac or cerebral vascular, so TIA, stroke, or peripheral vascular. So we're going to talk later on, I believe these triptans basically work through the vasculature by helping promote blood circulation. Be careful in your clients or giving it to clients who have uncontrolled hypertension, since we see here that it decreases blood pressure. And if you take too much of it, you may produce some sort of tremor or even decrease your respiratory effort. So here is kind of just this algorithm, right? We're going to teach them or watch them for headache triggers. We want to teach them good sleep habits if possible, diet and exercise, or that's everything health promotion maintenance, right? So relaxation techniques, that includes us making the rooms less noisy, less stimulating, so that the clients can get a lot of rest. We want to make sure that we're treating migraines early on in the process. Again, start least invasive to most invasive. And I would say this one here is probably one of the bigger ones that I do see. Again, because overuse of these medications is a real big deal because of all the bad side effects. So we want to make sure that if we're going to use these more moderate severe headache medications, your triptans, your topramates, if that's not prescribed to you, that you are going to use them as needed. So we do have multiple types of these triptan medications, and again, just look for the ending. They're all triptans. They produce a vasoconstrictive effect. Those medications we know are most effective when the client is taking them at the onset of the migraine headaches. Another medication that we can add into there is ergotamine, and we're going to see this produced with caffeine. So I'm not even going to attempt to pronounce that. Dihydroergotamine, right? So that's going to be one of those medications to help decrease inflammation that we would associate with that kind of vasoconstrictor effect. And then we have our isomethine. It's a combination medication. You can use that, but usually you only see that when these other medications aren't as effective. So again, from my perspective as a nurse, we need to teach them about triptan, these medications. We need to make sure that we're talking to them about the add-on medications and the fact that most of them are going to contain some sort of caffeine. Maintain a cool, dark, quiet environment for them. Make sure we have the head of the bed elevated to at least 30 degrees. Positioning will help with them. And again, that's also because of the decreased muscle tension. And then make sure we're giving them medications as prescribed. Tension type headaches. Again, we're going to basically be looking at our aspirins, our Tylenols, acetaminophen, our NSAIDs. We're going to use those maybe in combination with a sedative, a muscle relaxant, or a tranquilizer. Make sure that we teach them about the fact that drugs containing Tylenol, acetaminophen can cause kidney damage. We're always assessing those LFTs. You can also add preventative therapy, your tricyclic antidepressants. So you're thinking of an amitriptyline, nortriptyline. You see topramate, Devalporex, or mirtazapine on there as well. Cluster headaches, we said that those are going to be the ones that are brief and they don't last nearly as long. Basically, we don't have a warning sign that something's coming on. You can have that lacrimation, that tearing of the eye, the runny nose, the nasal congestion, the facial swelling, changes in your eyelids or eyelid edema. You can have pupil constriction, pallor, flushing, and then you get into the really bad ones, bradycardia, nausea and vomiting. And it can mimic kind of like anxiety. So you maybe see a lot of pacing, walking, or sitting with rocking, and that's because of the pain. So overall, just looking at headaches from a general nursing perspective, we need to understand that if you're going to see a headache on NCLEX, it's probably going to be a migraine headache. That seems to be the biggest chronic issue. We talk a lot about our medications, your triptans. So which medications should the nurse expect? Look for that triptan type of medication. But I would say first, make sure that you're looking for Tylenol, acetaminophen, because that's the easiest thing to do. It's exactly what we teach you when we're talking about your cardiovascular drugs, and we're going to give them Tylenol for a headache. Your ergots, right? Ergots are very specific for pain relief, and so that they only basically work for headaches or whatever type of headache. So it will not relieve any pain. It's not headache pain. Your add-on medications, your anti-epileptic medications like Topramate, your calcium channel blockers, your beta blockers. You can throw in a corticosteroid in there. And over here, I kind of just gives you different examples of the medications that you would be looking for. Again, I still say that if I were looking for something from a testing standpoint on NCLEX, I would look at, your acetaminophen, your ASA, ibuprofen, naproxen. Not really big on opioids, but we can see our triptans, and again, there you're just looking for the end of it. And then you have your combination medications, which is basically your aspirin with Tylenol and caffeine, or you can even combine your triptans with one of your NSAIDs. For clients that may have these reoccurring signs and symptoms, these clients that need more aggressive management, we could send them home potentially with oxygen. Oxygen used will help kind of diminish the headache. It's basically oxygen therapy. We're not using it like an all-day thing. It's just a quick hit. We're going to teach them to remain in a cool, dark, quiet environment, keep that head of the bed elevated, wear sunglasses when you're going outside. We want to reduce any kind of that photosensitivity. We want to make sure that they know how to get good rest and sleep, make sure that we teach them about diet and exercise, relaxation techniques, avoid thiamine, MSG, nitrates, all the food preservatives that we talked about, and make sure that they are able to identify those risk factors. So we talked a lot about stress, anxiety. You can see it with excessive physical activity. So that's not what we teach anyway. And I think that excessive is the key word. You want to make sure that they are having moderate exercise. Fatigue, if they're overworking, if they don't have a good home, stress, life balance. And then, of course, if they're not sleeping, you can have issues. So that's it from, again, and kind of NCLEX test plan perspective. Migraines is the big one, making sure that you can differentiate migraines from attention, from a cluster, and what those kind of signs and symptoms look like is going to be beneficial for you. Looking at your acetaminophen, your NSAIDs, and then moving on to the more aggressive, moderate to severe type of medications, your triptans. And if you have any questions, let me know.